previously. And so one interesting thing about pigeons, I don't know if it came to play in this study, is that they can see into the UV spectrum. Many birds can, parrots can as well. And so they actually communicate with each other by looking at the, in the case of the parrot world, looking at the iridescence changes in the UV spectrum when they shift their body posture. So it's just an interesting way of thinking of solving problems. We don't have to necessarily go purely technological. There's many incidences of this. So early in COVID, dogs were trained to recognize and sniff for COVID. We see dogs for starting to recognize early on auras for seizures. So there's a long list of thinking differently. Okay, I promised you guys case studies on antibiotic resistance. So this is a new/existing area of concern in healthcare. So basically the WHO position is that it's happening everywhere in every corner of the world right now. Since the 1950s, the amount of drug resistance that is developed is almost reaching scary proportions. So drugs that were considered big gun, broad spectrum antibiotics when I was in medical school, there are bugs that have developed resistance to them. So then we had to develop even broader spectrum antibiotics that you really need a pharmacist or infectious disease colleague to approve and release. And now there's even examples of resistance to those bacteria and bugs. And part of it is inappropriate prescribing of antibiotics, so up to 50% of antibiotics are inappropriately prescribed. And it can be anything from diagnosing something as bacterial when it was viral, or it can be how we interact with the patient and the patient not wanting to accept a diagnosis unless they have a prescription in hand, even though it may not be appropriate. So, like I said, we're having increasingly expensive, increasingly big gun antibiotics that are also now no longer always working. So in 2015, we had a first breakthrough in decades called Sept. And so what drove this breakthrough was actually advances in being able to culture soil. So we previously weren't able to isolate Sept from the soil because we just didn't have the practices to be able to grow it. But now, through better culturing practices, we're able to grow this analog in the lab. So again, it's sometimes the technology needs to catch up to be able to enable us to look for solutions that we hypothesize are there. Okay, I also promised you a case study on drug repositioning. So when we look at how medications act, one of the ways we look at is what is the 3D configuration of this medication? And what is the target receptor site, and how do the two puzzle pieces fit? And interestingly enough, there are medications that are unrelated that have similar three-dimensional configurations, meaning that we can actually repurpose a medication to be used for novel application. So this came out of a collaboration with Stanford and Packard Computing Sciences. And basically they found, for example, cimetidine, which is a Zantac, so it's the over-the-counter heartburn medication, maybe, potentially, a good form for a specific subtype of lung cancer because of the three-dimensional fit of the drug into the receptor. Topamax, for example, can be used for migraines, for seizures, may also be used for inflammatory bowel disease, for the same reasons. So now take that, this is where we talk about the intersectionality of existing technologies. So take your large data set and your data bank of different three-dimensional drug configurations as well as receptor models. That's still a lot of data and that's still a lot of computing power. Now take an extremely powerful AI that has the ability to parse large data sets and do so quickly, as well as pick out patterns for what may be successful, and now you're suddenly leveling up on the existing process. Okay, we talked a little bit about personalization, so here's a case study of where 3D printing comes into play. So who here's ever had to wear a cast in their life?
Oh, I was going to say I didn't wear, but actually one of the things that I was working on in my field is designing 3D printed prosthetics and orthoses.
Perfect. And do you have any insights from what you learned?
No, but I think those were around in a long time actually, as of now. but like they have many benefits in comparison to traditional ones. For example, the one that's showing in the picture, I think it's very easier, for example, to go to the shower with, or like
That's exactly
layering
it.
it. Yes. So
Yeah.
these kind of benefits, definitely
Yeah.
come with it.
That's exactly
And,
it.
I'm sorry, for prosthetics, for example, if somebody has lost their jaw, or like a part of the jawbone or anything in the face, so aesthetics also come into the play because they want to have symmetrical design, and like the aesthetics is also important because it's in the face and both patients, that's what they want. So I think in that area also it plays a very important role.
Yeah, that's exactly it. So when we look at custom 3D printing, definitely in bone flaps, so in neurosurgery where there might be a trauma patient who is missing part of their skull due to trauma, definitely it's part of reconstructive surgery where they have personalized prostheses. So who here has worn a cast before? Yeah, was it comfortable? No. So
And
they
like
get-
after like a while, it starts like smelling through.
They definitely start smelling, they get hot, they get itchy, if you have to wear them in the summer, they're awful. And then if you were unlucky enough to get a bump or a cast that was tight, it could be rubbing on a specific bone for a really long time. So customized casts, which still haven't made it to the mainstream, but for the reasons that you pointed out, they can be made to be waterproof. So you can bring them into the shower. You can customize them to the fit of your arm. So if you have very prominent bony prominences, you can maybe put some pressure there so you don't have that skin breakdown. You can 3D print too. So these are dishwasher safe, by the way, so you can put them in the dishwasher and you can wash one so it doesn't get smelly. You have the trabeculated version here that allows for air exchange. And then this was an innovation out of Russia where they experimented with high-frequency ultrasound therapy, which actually in their study was showed to accelerate the bone healing by 33%. So in an adult, you have to wear, on average, you have to wear a cast for about 6 weeks. Everyone's a little bit different. So if you could decrease that time by 2 weeks, I think most people would be very happy with that. Did you want to add anything?
No, I think also it's maybe easier to use, for example,
Yes.
and to wear and just take it out by the patient himself.
Exactly. Cast care is notoriously finicky, as I'm sure you've learned. Okay. So I think this is one of the last case studies on personalization. This came out of Harvard Medical School where they sequenced the human genome, but that is a lot of data to parse. So oftentimes there's this gap between academia and what holds promise for actual clinical application versus what doctors have time to learn about and to apply in a way that will benefit patients. So if Harvard Medical School were to send me a 60-page report for every single patient, I would not have time to read that nor apply it. What they've done instead is they've created a one-page summary of areas of interest that would actually affect clinical practice. So a very relevant example is, so they looked at disease risks, carrier risks, and most interestingly, pharmacogenomic associations. So they looked at drug sensitivity. Are you more likely to be sensitive or resistant to a certain medication? So if you're more sensitive to a blood thinner, you would need a decreased dose. Or maybe if you get the usual dose, you may be more prone to trauma, bleeding, bruises, or spontaneous bleeds, which if that happens in the brain or internal organ can be catastrophic. Okay. We talked a little bit about an increasing need to make healthcare participatory, and that includes not just communicating with the patient, not just getting their take on how they would like to be treated, but taking into account patient context and lifestyle. So we are hearing now, for example, the Surgeon General in the US has declared social media to be a significant health detriment to adolescents and young children. Here's a study out of Duke University that looked at risk factors for heart attacks, and they've studied divorce specifically. And what they found out was actually that multiple divorces were especially high predictor of heart attack in women. And even if you're remarried, don't decrease with remarriage. So that was an interesting example of looking at gender-specific risks in the context of cardiovascular disease. Now, will it change practice? Probably needs a little bit more study behind it. But say you had a patient who came into your office, you said they were stressed and they were going through their third divorce. Maybe this is someone you want to probably pay a little bit closer attention to, send for a stress test. Maybe not. So there are clinical implications. Okay. So one of the last technologies we're going to talk about just in passing is immersive technology. Again, just very briefly because we have a dedicated lecture for it. So this immersive technologies, this is probably something you're all familiar with, having lived through a pandemic. So this is an example of remote meeting, learning, working. And so in the age of the pandemic, we've seen an increased demand for immersive technologies, immersive healthcare, both for meetings in the corporate world, but also for being able to deliver healthcare. So when we get to that lecture, so this is an example of one of the technologies with the company I work with Luxonic, and the radiology workflow that we have. So that's, I'm just going to leave it here as an example of an emerging technology, but we'll talk about it both during space medicine and the immersive technology lecture. Okay, so one thing we haven't talked about yet, we talked about disease, treating disease, better prediction, better personalized treatment. We talked about preventative health and not just treating health as the absence of disease. What about making ourselves better? What about enhancement? Has anyone ever thought of that? Are there any specific superpowers you would want?
Oh, that's, I was gonna say something like gene shopping, with the argument of like, now that we know the human genome and also kind of like IVF technologies being able to determine what the baby can look like and what your baby can be, what diseases they might be more likely to get, that kind of stuff.
Yeah, so there's a huge spectrum of discussion and ethical quandaries there. So in the 90s it was termed designer babies, and it's sort of like, well, on the one end, if you have if you know are a known autosomal dominant carrier of a very life-altering disease, you would probably want to know that. If you're, so real life example, I have a colleague who is BRCA1 positive, very strong history of breast cancer, has undergone double mastectomy, so is going through IVF because she wants to be able to ensure her children do not have that propensity for breast cancer. That is an ethical use of gene selection. However, if the quandary goes then into, well, if definitely in certain parts of the world, certain genders are prioritized over others, so then we get into this slippery slope. Coming back to the initial question, what other types of enhancement?
So I was going to talk about two things.
Yeah.
I know one that's kind of gone viral right now is limb lengthening surgery. A lot of people have been trying to do that, and I think that's like a crazy thing to think about because even though I feel like to some extent, because I'm like a sports guy, I feel like that would be like
advantage,
yeah, it could be, but I feel like a lot of like people find that the long-term detriments kind of outweigh your ability to actually perform. It's more of like an aesthetic thing that like people feel insecure in their height. But then at the same time, if you do think about things that have worked in the sports world, there's like players like Lionel Messi, who I'm not sure if this is 100% accurate, but they've taken like hormones and growth hormones to increase their height to become better players, and obviously he's a brilliant player now. So that makes you think that if there are like certain advantageous traits, for sure to have like a longer wingspan for basketball.
Yeah.
I know Messi has a really low center of gravity, which a lot of coaches say that's really advantageous. It makes you think that if you have a parent or someone who's like wanting their child to go into professional sports, they might try to cater their child to develop certain characteristics that would make them more proficient earlier on.
Yeah, definitely. And so that, I mean, there's a couple of ethical quandaries there. So in Olympics, in professional sport, highly regulated, but now, I forget the specifics of this case, but there's a billionaire who says, well, I want everyone to be enhanced so they can perform at their best. He wants to create an extreme sporting league where people are just drugged out to the max so they can have these, they're doping with EPO, they have higher concentrations of red blood cells so they can have better speed, endurance, etc. So then the question is, well, I'm a consenting adult, you can't tell me how tall I can or can't be, as long as I'm informed of the risks in medicine. When we talk about informed consent, we talk about telling the patients the risks, benefits, side effects, alternatives. So if I wanted to do something dicey, like grow 4 inches, who are you to tell me what not to do? I'm not saying that I subscribe to that. And so then this whole spectrum, human enhancement is already here to the point where there's entire body modification conferences around this. There are people who willingly inject ink into their eyeballs, so they have red colored sclera, they have black colored sclera, they put in eyeball magnetic tattoo piercings. Again, not recommending any of this. So here's an extreme case of accidental memory enhancement from the New England Journal of Medicine, where they were performing deep brain stimulation. And the idea was to perform it for epilepsy surgery. And then they accidentally created an eidetic memory. And so this patient now had a photographic memory, which, if you're an undergraduate or graduate student, who here wouldn't want a photographic memory, right? So then it's sort of like, but brain surgery is not without its risks. And what about the costs? Because presumably this would be an elective surgery, very, very costly. So now you're creating a further divide between people who have money and access to enhancement versus folks who are now subsequently kept further out of achieving next goals, next career goals by virtue of living in poverty or even not just being extraordinarily wealthy. And so this kind of paves the way for Neuralink, which is, of course, the neural implant company founded by Elon Musk that has initially had some success. They had patients with either brain injuries or quadriplegia who had neural implants that allowed them to regain some function. So we talked about, well, where does that spectrum end between helping achieve functionality in day-to-day life versus wanting to do this for elective purposes? And then also the downside of, there was actually a lot of controversy that came out last year about how many undisclosed infections, side effects, adverse effects, and how much pain there was amongst the primate subjects that Neuralink was actually tested on. So again, this is just to prove, to hammer home the point that any emerging technology we have to think about critically and think about what are the pitfalls and how do we get there ethically, and then how do we identify that land of unknown unknowns. Okay, so here's a summary slide of most of the things that we've talked about already, including a few other technologies we haven't really talked about. So when we talk about big data, we talk about large data sets, parsing them, applying different filters like geolocation. So if you look at Google searches in different parts of the world at different times of the year, that actually can give you insight into population health trends that we weren't previously aware of that suddenly become apparent. There are doctors who actually prescribe smartphone apps for healthcare, for health monitoring. So MyFitnessPal is something a lot of patients use to be able to track their intake, their activity, their weight loss, as an example. Principles of medicine. So we talked about the 6 Ps. We also talked about faster, better, cheaper, smaller. Like if you were able to squish a doctor's visit for your annual medical into, there is a smartphone app that recognizes you're due for this, that auto-generates your blood work that you would be due for your age group, can create a point-of-care blood test, draw a bit of blood, analyze it on the spot, send the results to your doctor so that you're both set to prepare to discuss that. Who wouldn't want that? It saves you all a lot more time. And then we talked about the rest of these, except for nanomedicine, that kind of comes back to the principle of smaller, more targeted therapies. Okay, so the last 10-ish minutes or so, we're going to talk about getting from here to there. How do we get to innovation? What are some mindsets we can use to move out of yesterday's thinking into tomorrow's thinking and do so in a way that's both applicable but also ethical? Okay, so this is borrowed from Harvard Business School, Principles of Fostering Innovation, People, Mindset, Environment, Experience. That's on the show. Okay, so let's talk about people. So when we talk about people, we talk about not just operating our own silos. As a doctor, there's only so much I know. And as an emergency physician, I know a lot about emergency medicine, particularly in resource-limited scenarios. I know a lot about space medicine and the considerations that come up with that. Do I know everything about neuroscience, about neurology, about dermatology? No. I phone a friend when I have a patient with a particularly complex case. Taking that a step further, you are in a room full of psychology majors, data analysts, or statistical and data set scientists, biochemists, and more. And so what I encourage you to do over the course of this class, and we'll have workshops on getting to know each other's backgrounds better, is figuring out what your interests are and figuring out where your gaps are and fostering those communications, because you have a whole 3-ish months together. And if there's something that you come to this class very intent on learning more about, or problems that you want to learn more about that may be outside your field, there's a lot of resources in your fellow classmates as well. So we're also going to have a workshop dedicated on building on ideas and generating ideas. But basically the point is that there is a reason you have your own domain of expertise first, and how we learn to build working cross-disciplinary teams. So you don't need to be a brain surgeon and a rocket scientist. The other thing is about working in teams and how we work together is oftentimes we think about leaders and followers. Instead, I encourage you to view your relationship in professional and personal environments as a mortar between the bricks model, in that it's so easy to think of leadership as strength, but the reason I talk about leaders as mortar between the bricks model is it's so easy to think of the strength of a brick wall as coming from the bricks themselves. But if you take away the mortar, the brick wall falls down, right? So your job as a teammate and as a leader is to look for the gaps and to build those ties, to build that strength in those relationships. And so that's another framework for working within teams. Okay, so when we talk about mindset, the first thing I want to say is question everything. And I think the two most powerful words I want you to start thinking about as you go through this course is thinking about the potential and the possibilities in the world around you, viewing it as it is, but then asking how can it be made better. So the first question is, how can this be better? And then how can you personally make this better in the context of your expertise and experience? So here's one of my favorite case studies. This is, she was at the time 18 years old. Her name is Anya Pogarian, and she was volunteering in a hospital, and she was working on the kidney dialysis unit. And she was looking at how large and expensive dialysis machines were. They were tens of thousands of dollars. They were not portable. So what happens if you don't have access to be able to come to a hospital, you can't do home dialysis, there is a disaster response scenario. So she actually somehow engineered a suitcase-size dialysis unit that was an order of magnitude cheaper that could be made to be portable. And so it was simply based on that concept of how can this be made better. So we're about down to the last 5 minutes of class, but I just want to also encourage you to ask, what if? Think about possibilities, because I hope that there's at least some technologies here today that you didn't foresee coming on the horizon, that you didn't know existed within medicine. Because there are pockets of innovation that are even far beyond what's contained in these slides that exist today, but are just looking for accessibility or applicability or even funding. And the challenge sometimes is making something marketable or even changing attitudes, because with a lot of us in medicine, with this do no harm or that's not the way we used to do it kind of mindset, we're actually quite refractory to adopting new innovations. Okay. Not sure what's happening with my slides today, but oh, yeah, so these are some of my TED Talks on the subject. So they're included in the slide deck, but there's one on discovering innovation, and then there's one on innovation, and there's one on discovering exploration, and what on the power of asking what if. And so taking a step back, we talked about technology, we talked about innovation, we talked about high tech, but sometimes what if is just a different way of thinking. Does anyone know who this gentleman is? So his name is Ignace Semmelweis, and he was a physician in the 19th century, and he had this crazy idea for which he was ostracized, and basically he asked, what if all of these women post-childbirth were dying of puerperal fever and sepsis and infection because we're coming straight from the morgue, not washing our hands, and then attending to childbirth? What if we just washed our hands? That seems very common sense today. He was ridiculed, mocked, and ostracized because of this suggestion, and lived out his days, very, very sad, in isolation, in a mental institution, actually, because of this. But basically, he said, when I look upon the past, I can only dispel the sadness which falls upon me by gazing into that happy future when infection will be banished. So at least, hopefully, there's some silver lining to the ridicule with which he was derided for suggesting we should just wash our hands. So the conviction that such a time must inevitably sooner or later arrive will cheer my dying hour. Okay. So the next thing, we're going to go through a couple more slides, and I just want to quickly talk about disruptive thinking and anticipatory thinking. So let's talk about exponential thinking. So when we talk about arithmetic versus geometric sequences in mathematics, we talk about if we're talking about an arithmetic progression, we talk about a linear advancement. So if you're on a treadmill, you're increasing your rate of walking at 1 kilometer per hour, then 2 kilometers per hour, then 3, then 4, then 5, then 6. So it's a very predictable progression, very easy to keep up. But we're suddenly changing this to a geometric progression in which we're thinking we're progressing exponentially. If you're on a treadmill, you're running at 1 kilometer an hour, very, very slow. Then you're doubling that to 2 kilometers an hour, then 4, then 8, and by 16 you're starting to run, and by 32 you're probably flown off the treadmill and hitting the back wall. And so when we talk about exponential thinking in the terms of technology, let's look at some case studies. So how long did it take the radio to reach 50 million people? Do you think? Just some guesses. When it was first deployed. Did it take weeks, days, months, years? Yeah.
10 years?
10 years. Any other guesses? More? Less?
Maybe like a year?
A year. It took 38 years, sorry. Okay, Facebook. How long did it take Facebook to reach 50 million people? More or less time? Less. Okay, how many? Months, weeks, years?
5 years?
Yeah, you're very close. 2 years, okay? All right, when Adele, when she came out with her Hello video, how long did it take to reach 50 million viewers?
1 day.
1 day, 2 days, okay. So that is what we mean by exponential change, is that not only are the technologies changing, the pace with which they're adopted and disseminated are also changing. That is exponential change right there. Okay, so then let's talk about thinking disruptively in terms of being our own disruptive force. Okay, so this is a corner shop bookstore. Somewhere in the 90s and 2000s, we saw the big box bookstores, Barnes & Noble, Indigo, Chapters. And then what took the place of Barnes & Noble? What was the next thing?
Kindle, maybe?
Before Kindle.
Ebooks? Oh.
What was Amazon before Kindle?
Oh.
It was a warehouse. And so Amazon was the threat to Barnes & Noble because now you could get any edition, any book, because they didn't have to worry about stocking the shelves in the big box bookstore. So now Amazon was a threat to Barnes & Noble. Rather than waiting for the next threat to put them out of business, they came up with the Kindle. This is what I mean by thinking exponentially and also being your own disruptive force. So same thing, who remembers this? Anyone around? Okay, Blockbuster Video. Once upon a time, some of you may not remember this, on Friday nights, we would go to the video store, we would grab a VCR, we would be fined if we didn't rewind, and then we would return it. Then Netflix decided they said, well, why would anyone want to leave their house? What if we had a mail order DVD service where people could rent through the mail? But then they thought, well, what's going to replace us? Internet streaming. They saw that intersection of not just accessibility, but internet streaming services. So they became the first and put Blockbuster out of business. But now what's happening with the landscape is there's Hulu, there's Crave, there's Disney Plus, actually I can't keep up with it all. Okay, so I'm going to go to the conclusion now because we are just about at time. So for your homework, this is totally optional. I'm not going to ask you to turn it in. Just to kind of see how technologically disparate we are in this day and age in 2024, here's a case study for a family that opted to live like it's 1986 because they felt they were so dependent on technology. If you were to go through the thought experiment and put yourself into 1970, it would feel like withdrawal and isolation because we are in a whole new era of disconnectivity that we're not used to. No, if you leave the house, that is it. There is no portable phone with you. You know, if someone goes out, if your loved one goes out to work, you're not hearing from them for 8 hours. Are they having a good day or are they dead? You don't know. So going through the thought experiment of what it's like living in different eras, and then the 3 questions I want to ask yourself is, what are jobs that didn't exist 10 years ago? If you go back to 1980 and somehow put out in a newspaper looking for a smartphone developer, are you going to get any bites? You're not. And so there's a whole long list, and I'd be very curious to see what you guys come up with. But in addition to that, what are jobs that will not exist in 10 years? Because we're already starting to see this with self-checkout checkouts in retail stores. We're seeing this with travel agents being replaced by Kayak, Travelocity, etc. We're seeing taxis competing with Uber and Lyft. So then the next question that I want you to ask yourself is, what are jobs on the horizon that don't exist or may exist in 10 years? So this is really interesting. I kept this list the same because when I came up with it, extinction revivalist, commercial astronaut were not yet on the horizon. However, in this day and age, I'm now a commercial astronaut. Also in this day and age, companies like Colossal are literally aiming to revive the woolly mammoth. Their argument is it can help foster ecosystems in the Arctic. Take that what you will, but I've seen Jurassic Park and I know what happens. Okay, so I'll just leave it here. So when we talk about medicine in 10 years, what do we think it's going to look like? What do you want it to look like? Where are we headed? What are the best and worst versions of medicine, and how do we be mindful of that? Is it going to be AI driven? Is it going to be an integration with immersive healthcare? Are we moving towards two-tiered access? How do we get to be more predictive and personalized? How do we deal with this in the face of an aging population that's going to reach about something like 25% by the year 2050? And then what new positions do we need to be able to navigate that? Do we need healthcare system navigators? Do we need subspecialties, which we're already seeing the rise of? How do we combat pseudoscience and misinformation? And where does personal enhancement fit into all of this? So we're at time. Thank you all for the discussion. The slides will be available to you. And my email address is at the very end of these slides. So we'll see you next time.